so don't forget. It looks like the waiting room is cleared, but we still have about a minute before it starts. So we'll see if anybody else joins us.
Okay.
And I think that's what Phil, John, and Garth all logging in. Did I miss Joe? Is he here? Okay.
I didn't see his name on there, but I talked to him this morning of just texting back and forth, and he indicated I thought he was going to be here. So
Okay. It's just now 2 o'clock. So let's see. We've got a few people coming in from the waiting room.
Okay, we'll give it another minute or 2 or 3.
It's Julie McKee. I understand that you.
Okay. Excuse me. The waiting room is cleared. You do have a quorum if you want to go ahead and start.
All right. Let's want to welcome everyone to the dental TAC meeting this afternoon. Appreciate your attendance and interest. We will do it'll be kind of I'll call everybody's name, and it'll be kind of an introduction and a roll call at the same time. So I'm Garth Bobrowski, the chair of the TAC. Dr. John Gray.
Good afternoon.
And Dr. Phil Schuler. He's on mute. And Dr. Joe Petrie.
Here I am, Garth.
Okay, good deal. Thank you. Well, then we do have a quorum, and I want to let you all know that we are striving for another TAC member, and I've gotten a couple more people that may be interested, and I called their office today, and they won't be back, or actually called them earlier this week, but they won't be back until Monday or Tuesday in the office. So I'll know more next week on getting. We need one more TAC member, and I'd like to entertain a motion to approve the minutes from the previous TAC meeting.
John Gray, so moved.
I'll second.
Joe, go ahead, Joe.
Second, Joe Petrie.
Okay, thank you. All in favor, say aye.
Aye.
Any
Aye.
opposed? Now, the another thing I was just going to mention was going forward, I think one of the main duties of the Technical Advisory Committee is to be an advisor to the MAC, or the Advisory Council for Medical Assistance. For example, we need to look at some things that, I know we have specific things that come up from one meeting to the next, but one idea was developing specific ideas for policy development. And I think that's a critical thing that we can work with our administrators and our MCOs and try to get the best oral health care that we possibly can for our Kentuckians. So let's just keep that in the back of our mind, going forward. But I want to go into the old business at this time. And the first item of business will be Dr. McKee and Lindsay Meadows, and they'll be giving us a report on their dental health survey report. So Dr. McKee.
Thank you. Thank you very much. I understand that the host has disabled screen sharing, and Lindsay would like to share her screen to show our survey. Our survey was done during the wintertime, end of the wintertime. And we've just now had the opportunity to present it to you all and to see what's going on. Let me make a correction in the agenda. It's actually Lindsay Meadows with an R, O-R, with that. So with that, I would like to introduce Lindsay Meadows. She is the oral health epidemiologist. She, much to my benefit, loves to do surveys and write questions and do a lot of analysis. And that's what we're going to share with you. It's pretty short, and we will take questions either during or after to get your all's reaction on this. Okay. I see that Lindsay can be made a co-host. So I'm going to let you all work that out and get her screenshot up.
Lindsay, can you turn on your camera briefly? I can't find you. I'm only showing 5 people. I'm not sure if it's my view. Oh, there you are. Thank you.
You're welcome.
You should be able to share now.
Okay.
All right. Okay, can you guys see my screen? Oh,
We can see you, but not your screen yet.
okay, hold on. What
It
about,
looks like it's going to get, yes, there you go.
okay, perfect. Okay, just a second. Okay. Good afternoon, everyone. My name is Lindsay Meadows, and I am the epidemiologist for the oral health branch. Today, I want to share with you the results from our fall 2021 Kentucky Dental Practice Survey. This survey was designed for the actual dental practice itself, and this means that one single dentist may have completed this survey more than once, depending on whether or not they have multiple practices within the state. The survey asked questions ranging from location of practice, dental specialty, and numerous Medicaid questions. The objectives were to glean information about the dental practices, observe the attitude, perceptions, and behaviors towards Medicaid, access to care, and to identify challenges dental practices have towards accepting Medicaid. This survey was distributed to 3,140 licensed dentists in Kentucky, regardless of their specialty. We received 391 respondents to give us a response rate of 12.5%. There were 64 surveys that were returned incomplete or partial, and the data from those were accounted for in our data analysis, and they are included in the total of 391. So, who responded to our survey? As already mentioned, we had 391 respondents ranging from all different specialties and location types. This slide breaks those down. Majority of our respondents said they were a general dentist at 70%, followed by orthodontics and dentofacial orthopedics at 9%. Pediatric dentistry represented 8% of respondents. Oral and maxillofacial and dental public health represented 5% and 3% respectively. The other category represented specialties such as endodontics, prosthodontics, and dental anesthesiology. As for the practice setting, majority of our respondents were a solo practitioner with over half of our responding population. We're then followed by an employed dentist in private practice or an associate at 11.3%. 8.4% were group partnership DSO affiliated. 7.8% were group partnership non-DSO affiliated. 6.7% were educational institutions, government supported clinic at 4.9%, and the other category, which landed at 8.4%, included practices like for-profit corporations, charitable healthcare settings, and those who are currently not practicing. Okay. This map represents the frequency distribution of our survey indicated dental practice locations. The light blue represents counties where there were 1 to 4 survey indicated dental locations. Medium blue is 5 to 9, and the darkest represents 10 or more locations. We received responses that had dental locations in 70% of the state. I'll let you look at that for a second. Now we move into our Medicaid portion of the results. Less than half of our respondents accepted Medicaid at 47.7%, while 52.3% did not accept Medicaid. So for those who answered no to accepting Medicaid, only 36.8% of those respondents said that they had ever accepted Medicaid before at their office. So this slide shows the response we received when asked why their practice stopped accepting Medicaid. This question was only asked to those 36.8% who responded that their practice used to accept Medicaid but has now opted out. I'll give you a minute to look over this, but it is clear the top 3 reasons were low reimbursement rates, attitude of MCOs, burdensome paperwork, and high patient no-show rates. Okay, moving on. We then asked those who currently accept Medicaid which MCOs their practice accepts. The top 3 MCOs accepted were WellCare, Aetna, and Passport. All of the MCOs were accepted, just some not as much as others, and this slide shows that breakdown. The next few slides that we're going to take a look at Medicaid access to care. These survey questions were asked to those respondents who indicated that they currently accept Medicaid. The left is a chart that shows the breakdown of how many Medicaid patients are seen weekly at dental practices. Most practices see anywhere from 0 to 60 Medicaid patients, with 56 and 55 total practices respectively. If you look on the right, the pie chart indicates that 84.4% of practices are accepting new Medicaid patients at their office at this time. This slide shows the breakdown of age ranges seen at Medicaid dental practice locations, including both new and existing patients. It is clear that the adult Medicaid population is lacking as it doesn't compare to the rates of the children. I'm not sure why that is exactly. This slide shows the times Medicaid patients can receive care at Medicaid dental practices. Majority of practices see Medicaid patients daily, all day, Monday through Friday. Almost 100% of practices practice locations see Medicaid patients in the morning, with a very high percentage in the afternoons. Saturday and Sunday, there were only 6 total dentists who responded that they worked and seen Medicaid patients these days. And if you look at the bottom of the slide, it tells you how many respondents we had for each day. All right, so this map here represents the frequency distribution of survey indicated dental practice locations that accept Medicaid across the state. The lighter blue indicates there's only 1 to 2 locations that accept Medicaid in that county. The medium blue is 3 to 4 locations, and the darkest blue indicates 5 or more Medicaid practice locations. A little over half, at 53% of the state, has at least one Medicaid dental practice location. 47% had no Medicaid dental practice at all, indicated by the gray, according to the survey results. This is just a comparison of the overall dental practice locations compared to the Medicaid dental practice locations. You can see that there are more gray counties on the right, meaning there are no Medicaid accepting dental practices in that area. And for those counties that are shaded light blue, there's only 1 to 2 dental offices that accept Medicaid, which kind of makes it really hard for those bare spots in Western Kentucky and Eastern Kentucky to receive Medicaid care, dental care. I think this comparison shows the true need for Medicaid dental access to care improvement. For example, the folks in Eastern Kentucky who are on Medicaid could potentially have to drive as far as an hour and a half just to be able to go to a general dentist. Make it a 2 to 3 hour commute if they have to go to Lexington or Louisville to receive a specialty. And I do think this is a barrier that we should absolutely try to break through. And I'll give you a couple of seconds to look over that comparison. Okay, so this question, it was asked to all survey recipients as we wanted to know everyone's thoughts on this issue. We asked this in a forced choice approach, meaning the respondent had to commit to an answer. This type of question forced the respondent to provide a separate yes or no answer for each item without using bias. The top 3 challenges that 72% or more indicated was reimbursement, burdensome paperwork, and broken appointments, non-compliance. Like earlier in our earlier slide, this mimics that, where we were given the answers as to why the dental practices stopped accepting Medicaid. Okay, I'll give you a couple minutes to read through these little blurbs that were submitted along with the surveys by dentists. All the dentists have issues or negative experiences regarding Medicaid. All the dentists are very passionate about the work they do and the treatment they provide this population of patient, but things must change to make this system work for everybody, not only the Medicaid population, but the dentists as well. You can feel their emotion and stress when you read through some of these comments and blurbs. Do you all need a couple seconds, or have you read through them? Okay. So this brings us to any questions that you guys may have for myself or Dr. McKee.
Did you break any of the data down by the specialties beyond the response rate, realizing that you had a low response rate by
Mhm.
specialties in of their own?
We did not break down any further, but that can be done. If you all would like that information.
I think historically in our TAC meetings, we've discussed access to care issues, but specifically specialists and even more specificity with oral surgery has been such a challenge for our patients that I think that data would be even more telling.
Okay. Let me write that down.
And we can come back to the next TAC and give that.
Yes.
There
Thank
was
you.
one of the little windows on that last slide. I was trying to quickly scan and read through them. One of the comments from a dentist was that, well, they up in the upper right corner, I guess they didn't have. Let me shift this view on this screen here. They had it says no effort is made to discuss the program with all dentists. No effort is made to address major issues that prevent dentists from accepting Medicaid. But I'm gonna kind of take up for a lot of folks here, because I know we got a KDA annual meeting coming up here at the end of this month, and we're specifically having a Medicaid forum, which is going to have a little bit of CE in it, but it's also going to have opportunities for dentists to come and speak their mind or ask questions, because we're going to have the MCOs there, commissioners going to be there. So that's one part. And I know the MCOs have all kinds of phone numbers and provider representatives to handle the daily calls. And I'll brag on Commissioner Lee. She's even told me to give her phone number to folks that are having some issues. So, I think we've touched our bases. Now, of course, some of the Medicaid providers aren't KDA members, so maybe they don't get the information coming from that source. But I just want to take up for everybody here on that comment. So I just want to say about that one.
Dr. Bobrovsky, this is Julie, and I think that's an excellent point. Our issues are a couple of things and Lindsay and I have talked about this, and one of the unfortunate things, and I speak as a KDA member, KDA, only about 42% of general dentists belong to the state association. So even less than that go to the meetings. Maybe there ought to be a non-KDA. Oh, and let me say something else. It is my perception, it is not data driven, but it is my perception that the Medicaid members are likely not KDA members. Okay, so I finished that. Maybe we need to look at other platforms with media, social media, and other outreach to get to the dentist, Medicaid providers and non-Medicaid providers.
Hello. I'm on a Zoom call, so you might hear some.
Yeah, we hear you. That we can lay it out for them and answer the questions that they have. I'm sad to say the KDA session is not going to reach the people we need to reach.
In the past few years, pre-COVID, I know there were some Medicaid meetings that packed the room. I mean, there were. I know one meeting I was at, man, there was I mean, I don't think they were packed in there tighter than sardines. And if the fire marshal would have come, we'd have got in trouble. But I think that was a little bit before. And I know the last few years, with COVID and everything, I'll blame it on. Let's blame it on COVID. The attendance was down, even though we had a pretty good bunch of folks last year at the forum. But you're right, Dr. McKee, that I think there are methods. Now, I do know that the KDA staff and Executive Director, Mr. Whitehouse, did send out several notices to all dentists across the state about Medicaid issues. Now, they don't go out every time, but I know several times they have included all dentists across the state. So we just need to tell them, well, they just need to become members if they want more information. So, that's it, my little report on that part.
Garth, this is John Gray. Hello.
Oh, yeah, go ahead.
First, I'd like to compliment on that study. I think that's very descriptive, extremely well done. And as soon as you look at it, you get a feel for what the problems are, where the problems are, and what the access is. And so I just, Julie and everyone involved need to be complimented on a study, I think, extremely well done and very reflective of the problems we're facing. And when I say we, it's really not we, the problems that the people of Kentucky, the patients of Kentucky, are facing. A mention was made about the emotion in the dentist. And I feel that every day that I see patients. I saw a patient with abscesses and it took her 6 months to get in to see me. She had a consultation appointment. We went ahead, the staff worked through lunch and took care of her because she'd waited so long. But I just find that to be totally unacceptable. It's not it's not the dentist. I mean, we're having a problem, but the real problem is the patients. As I told the TAC committee earlier, we had a dentist and oral surgeon signed, ready to come in September. And I'm not sure if she looked at the amount of Medicaid and realized, as my son-in-law did, why would I see 3 times the amount of patients for the same amount of reimbursement? That's not a good plan. So bottom line, she's not coming and I'm still working. It's coming to the point that there is the 6 months is not going to be enough. And to say that we have insurance coverage or that we have medical coverage or we have a plan for people in Eastern Kentucky and Western Kentucky where you can see these gray areas, I mean, it's not real. It's not real. And I think the map really shows that. So thanks so much for putting it together.
This is Lisa Lee. I have just a couple comments. Agree that this was a really good presentation, had some very helpful information in it. I think the one thing that kind of jumped out at me that continue as a Medicaid commissioner that continues to bother me is the comment that Medicaid members are rude to our dentists. Everyone can be rude at some times, and I think that there is a little bit of a misperception about Medicaid members. I mean, the population that we are serving have several strikes against them, if you will, to start out at number one, that they live at or below the poverty line, which makes them more susceptible to issues related to social determinants of health, education, food, housing, clothing that can impact their lives and their health care. The other thing that I'd like to note is, we do cover 1.6 million people in Kentucky Medicaid. I say that's nothing to boast about. at all, because that means 1.6 million people live at or below the poverty line in Kentucky. The other thing that I'm curious about that I don't think we look at enough is, Medicaid is 1.6 million individuals, and so therefore approximately that many have access to dental care. And I've looked at a map. I'm just sitting here kind of looking, for some, what percentage of the general population has dental insurance. And hate to say this in a dental TAC, but I don't have dental insurance. I have to purchase it separately. I found that the cost for my dental insurance was a little bit too much for what I got in return. A lot of things considered to be cosmetic. So I'm fortunate enough that I can pay for my dental care myself. And looking at a map, I see that Kentucky is significantly, that about half of the people in the United States actually have commercial dental insurance. And then when you look at Kentucky and most of the other southern states, they show that it's significantly lower. So I just, curious as to how we can find out how many people in Kentucky actually have private dental insurance. How are their utilization patterns? And I think that's another study that we could look at as we go forward. But again, I think the misperception of Medicaid patients in general is something that we definitely have to overcome, and just know that the individuals have healthcare issues that need to be treated, and unfortunately we don't have an infinite supply of resources in which to do that. But again, I really liked the presentation. I had great information in it.
Mr. Lee, John Gray again. I would say, since we treat a large volume of Medicaid patients, a substantial number are very rude. And when I say that, I don't want to be misinterpreted, but what I'm saying is that we just hired a girl a month ago, and she quit after 3 weeks after being cussed out on the phone 3 days in a row. When you cannot get care and you are in pain, you're not very friendly. And that's the position that the patients are in. And I get that. And we end up having to make up for the fact that we can't get them in. There's just no way to get them in. Sometimes 2 or 3 months. They are frustrated. They're angry. They think they have care and they don't. And they take it out on the staff. Not many, but if you answer 40 calls a day and 2 answer that way, it makes our people at the front not very happy, not thankful to be there. Feel like that we're doing all we can do and we get no thanks for it. It's just saying thanks for working through lunch. Thanks for working after hours. Thanks for coming in. Thanks for doing it when nobody else will. We get cussed at, yelled at, screamed at. And I don't think that's necessarily their fault, because when I'm in pain and I hurt at the end of the week and my neck is uncomfortable, when I come home, I'm not a nice person either. So I get that, but it is a real issue, and it may be a justified issue, but it is a real issue, because unless we get access for these patients in a timely manner where they can have their immediate needs taken care of, they're bound to be frustrated. So that's just a comment.
Yeah, and I understand. And I guess too, when we talk about access and limited number of dentists, is part of the issue too, that I know recruiting dentists into the state is one issue. If somebody is outside of the state, they have so many more opportunities. But what about recruiting and training and finding individuals in Kentucky who want to stay in Kentucky? And, what can we do for that? And can we increase the number of dentists that are graduated each year from our teaching schools? I think, the last time I heard, there were just a couple of hundred that graduated from that each school, each UK and U of L, have a limited number of both in-state and out-of-state individuals that come into the dental program, and is increasing that cap and specifically focusing on individuals, for example, in our rural areas who may have an aptitude for dentists, and training them early on and getting them used to this, or getting them groomed, so to speak, for going into the dental field, and then having them, stay in the state. So I guess that's another issue, is the access and the number of individuals. I mean, I don't know that increasing the rate, I think that it does, that's going to help. I think increasing the dental rate's definitely something we continue to explore. But I also think if we're looking to recruit individuals from out of state, that they have so many more opportunities to go to other areas. So I'm thinking, just throwing that question out there, how many dentists graduate each year from UK and U of L, and are they in state or out of state?
Commissioner
Dr.
Lee.
Bobrowski, it's Julie. I've got 1.25 answers for the commissioner. Would it be okay?
Go.
First off, I'd like to tag on to Dr. Gray's comments. Thank you so much for that. And it is difficult to be polite when you're in so much pain, but on the provider end, it also costs time to manage that patient's anger and frustration, and that adds on maybe just a few minutes each visit, but over the day and over the week, it adds up. And with all the other things that add up, like medical management, that adds up. So that's not part of the answer to what Commissioner Lee was talking about. I have a small answer and a bigger answer to that. Through special funding, we are able to offer loan repayment to 2 graduates from U of L and 2 graduates from UK that will be selected in this coming year. There's lots of parameters that need to be hit, but areas of need and acceptance of Medicaid are definitely the drivers of this. We will be reimbursing them over the course of 4 years of an agreement, $200,000. $200,000, parentheses, tax-free, goes a long way on student debt coming out of our schools. So is that panacea? Absolutely not. But it is a demonstration project that we can make it happen and maybe get other funding to continue supporting 2 dentists from each school. So as I say, each school, today it's 2, in a few years, it's going to be 3 schools. The University of Pikeville is trying to develop a really kind of, I can't say it's unique because there are other examples in the United States, but it's a non-traditional dental school that from the recruitment of their students, they want to get people that are interested in serving underserved areas, rural areas, Medicaid populations, other vulnerable populations. And you're going, yeah, right. Well, this has been proven in other types of this school. The A.T. Still School in Arizona has probably I would say a 12 to 14 year track record on putting dentists back out into vulnerable populations, however you define vulnerability. So a little bit of shaking loose, but on my part, if we can prove that these people want to take this loan repayment program and are begging for it, I can easily beg for more money. I don't care. I can do that. I can beg for money. But so I'm done.
Commissioner Lee, here's another factor that may tie into why sometimes the younger, the dental students are not going into the rural settings or not accepting the Medicaid patients, even though I know some do, but high school indebtedness. I think the national average, and someone please correct me if I'm wrong, but the last I heard that when these students graduate from dental school, the national average is about 306,000. And I think just 4 or 5 years ago, it was 260,000. So, I mean, you talk about just being fresh out of dental school and you're slow as molasses on a January day in delivering care because you just don't have the experience yet to pick up your speed. That comes with practice and just getting out there and working. But these students are highly in debt when they come out of school. And Dr. McKee, I think that's a great opportunity for two people, to get in that and in over 4 years.
4 people, 2 from each school.
I didn't catch that part. All right.
We just doubled the population of dentists serving the vulnerable populations.
There you go. Thank you. But I mean, that's just, that could be a factor, the high debt that they're coming out with. So it almost forces them to go to your fee for service, insurance backed practices. But thank you all so much for that report. And could you please send that to Miss Erin Vickers? And
we've already discussed that, and it will be on the way soon. Absolutely.
Okay. And also to the TAC members.
Sure.
And
I can send it out to the TAC members, Dr. Borowski.
That would be great.
Okay. Thank you. And do we have permission to share this with the KDA Executive Board?
Absolutely. We are government, and so everything is public domain.
Okay.
In my way of thinking for this study. We have to have some kind of discretions in other places, but for this study, we'd like to get it out. We would, just because we're selfish and looking for self-paying, we would not mind redoing this in another interval to see any changes. Also, to let you know, I'm kind of glad you brought that up, Garth. Also, to let you know, there is a 3rd-year U of L dental student doing a different but similar survey of dentists. You may have already gotten it, and that is being overseen. The mentor for that is Sherry Babbage. Can't remember the dental student's name, but since they're not government, because government's out to get you and what have you, they may get a higher rate of response, and we think that'd be great. It's a little different because it's more attitudinal than ours is quantitative. But I think between the two, we're going to get a multidimensional picture about what we're facing. And I think Dr. Gray was absolutely right. It's the patients that are facing the real problems, especially with access. And we can all work on that. But yes, public domain, we'll send it to anybody who wants it. Anybody who's on here, we will also be glad to present it to anybody who wants it, another group or another practice or a component society. We'd be glad, and we'd love to get the feedback and share it back with you all. I think Lindsay's going to be signing off because she has other things to do and her part's done. Unless you've got other issues for me particularly, I'm going to be signing off in a few minutes because I am on vacation. I'm on a bay and I see people in their sailboats and their sea-doos, and I want to be with them.
Well, thanks for rubbing it in, but thanks for taking time to do the study, to both of you all, and then for the presentation too. Well done.
I'll be here for a few more minutes, but
okay.
I promised myself I'd be off by 3.
Well, and then I noticed there was quite a bit of comments about the gray areas on the map. But if you look at the TAC members, you got a lot of gray areas there, and one didn't even have any hair. So that's a joke, Dr. McKee. All right, thanks so much. And I know Commissioner Lee's got to leave in just a little bit too, but I kind of wanted to ask about any updates on the basic health program, or what's going on, or anything else you've got the floor.
Thank you, Dr. Bobrowski. A couple of things. So the basic health plan, we have put a little bit of a delay in it. We're looking at a date of January 1st, 2024 for the basic health plan. And just to give you just a little quick update on what a basic health plan is. It's a bridge plan, for example, for individuals who would be losing Medicaid before they would go on to the qualified health plan. It would cover individuals aged 18 to 64 who are between 138 and 200% of the federal poverty level. And it would look and operate very much like a qualified health plan on our state-based exchange. As far as the dental community would be, they would have to have a separate dental plan for any individual who was 18, age 18 so that those individuals would be able to get a dental plan. Others would be able to purchase a dental plan if they wanted to. We'll have more information for the provider community coming up on that, but right now we are looking at a date of implementation date of January 1st of 2024. I think some other news that would be interesting to this committee is in April, we expanded our coverage for pregnant and postpartum women. Typically individuals who are enrolled in Medicaid, we cover those individuals up to 185 or so, a little of the federal poverty level. I'd have to get that very specific number out, but we cover pregnant women in the Medicaid program at a higher level than we do our Medicaid expansion, for example. And when those women deliver their babies, typically they only had 60 days of postpartum coverage, meaning once they had their babies, and after 60 days, they no longer had Medicaid coverage. We have expanded that coverage up to a full year. So now those women, when they deliver their babies, they will continue to have Medicaid coverage to include postpartum care, and they will receive the full Medicaid dental, benefit package, which includes dental. So if you, for those of you who know that you have had pregnant mothers in your practice, that their eligibility will continue longer than the 60 days after they have that baby. And the other thing that we have been working on is, I'm trying to think as it relates to the dental program. We're still in the public health emergency. We have the maintenance of eligibility is still in effect, which means we have to keep everyone enrolled in Medicaid through the public health emergency. We have another public health emergency, as you know, in Eastern Kentucky due to the flooding. We have suspended prior authorizations, and we have also allowed for early refills of medication for those individuals who may have lost their medications or don't have access. So again, focusing on that area, and would like to really thank our Medicaid managed care organizations for assisting in some of the areas down there to make sure that their members are taken care of. They've been doing outreach to individuals to make sure that they're safe and assisting with some cleanup. And I would be more than happy to take a couple of questions if anybody has questions for me before I sign off. And I look forward to seeing some of you in person at the meeting up in French Lick.
No question on that, Commissioner Lee, but I'm sorry I lost my feed for a second there. I'm back on now. But when John first started talking about patients being some of the Medicaid having the root, my hackles got a little up, and then I realized his point with patients in pain, and that is absolutely, I'm sure, something he deals with. As an orthodontist, I don't deal with that as much. I would just like to say, when I read that on that report, that there was a response about Medicaid patients being rude. Seeing the volume of patients that we do, I would very much say that the Medicaid population that we see is the most rewarding patients that we treat. And I think that's part of the education of people to be able to want to take Medicaid, not just reimbursement, which we all know is a huge factor in it. But understanding that these are the if not us, then who? And I think that educating both at the dental school level, but also in the private practice level, what it means to treat this population. I practice in Hazard, Kentucky, and what is going on in that community right now is just heart-wrenching. But we have patients coming in that have lost their entire homes, and they're still coming into their appointments, and they're appreciative that we're open. You can't use our water. We're glad to have electricity, but we're seeing them. And I know John is seeing them in his offices that are still traveling up to see him. And that's rewarding. It's sad to see the situations they're in, but to be able to help these people in any way that we can. And so the sentiment on that survey, my hope is that is one person who maybe doesn't see as much of the Medicaid population as the rest of us, or someone who just had a bad experience. But on the whole, I don't think that's the sentiment. It certainly wouldn't be mine. But I think educating people that don't see that population, that the rewarding aspect of treating this population is a part of gaining access, getting more people involved, not just financially, but also because of the joy and the benefit of treating the population.
Thank you, Joe. Thank you for those comments, and everyone, thank you for everything you're doing for the Medicaid population. You know, I know I've expressed this quite often, that my philosophy is that the Medicaid program was created for the Medicaid member, and we can't take care of our members if we don't take care of our providers. We are here. We do listen. Sometimes there's, not. I think I've had one of my employees has said, sometimes if I had a money tree and I could just shake it, I would, give you everything I could. But, with the limited resources and trying to figure out how we can best serve this population to make sure that we improve their healthcare status as best we can. I know it's definitely a big job, and just like all of you on this call here, even though you're medical professionals, the individuals on the TAC, you're medical professionals, you're serving the Medicaid population, and that makes you just like the staff that work here at Medicaid. We are true public servants, and we are here to improve the lives of those that we serve, and appreciate your partnership. And again, look forward to seeing many of you in a few weeks up in Indiana. And I'll be here for about 9 more minutes, and then I'll have to log off. And as always, it's great to have you all here, and enjoy these conversations as we try to find ways to improve the program and reduce some of the administrative burdens on our providers. And let's keep thinking outside the box, what we can do. Sometimes if we can't reimburse, what else can we, what other policy is of a headache to you that we can kind of look at, maybe change a little bit to reduce some of that burden.
Commissioner Lee, this is Phil Schuler. Before your 8 minutes up now, I think, just a couple of comments. You talked about recruiting doctors, and I'm with Mortensen Dental Partners. We have 140 practices across 9 states, and I can tell you that recruiting doctors into Kentucky is hard because they know that of our offices, about 60% or so see Medicaid, and even getting them into the organization. I mean, some of the first things they ask is, do you see Medicaid? How much Medicaid? Will I have to see Medicaid, and those types of things. So, I mean, it does, kind of commenting to what John Grafe said, about his challenges recruiting. I mean, we see it every day. So it really is difficult because they know that they're going to have to do quite a bit more dentistry, see quite a few more patients to make the same amount of money. That being said, there was a comment about, U of L and U of K's graduation rates. We've almost quit recruiting U of L because almost everybody's out of state. Of the 120 some students who graduated last year, there was maybe 10 that were from the state of Kentucky, that actually wanted to stay. So, that kind of compounds things as well. They're really tilting their admissions towards out of state, doctors. You could say for higher tuition reimbursement. I won't put words in their mouth, but the fact is most of the students at U of L now are from out of state. So U of K is quite a bit different, but we're not putting out very many doctors that want to go into these rural areas. So Dr. McKee is, I love the fact that, we're going to get some tuition reimbursement for some folks that, even if it's just 2 per school, it's a start. And I would say beg for more money, because that would be a big incentive for somebody to go work in an underserved area for, 3, 4, 5 years to get that much knocked off your student debt. But just a couple comments about recruiting. I mean, recruiting in general right now is really, really tough, but recruiting into our Medicaid practices is especially difficult.
All right, I've got a couple of questions under new business, but is there any other old business that I need to touch on? Okay, under new business, and if Commissioner or someone else, if you, I was just wanting to know what is the cap, and if you don't have the answer right now, I just want to put some of these questions out there so we can start some research of like what is the capitation rate, you know, for Medicaid, MCO, dental per person, and then the second one was what is a community rating system and how does that to relate to Medicaid dental? I'm just trying to learn.
Well, that's good. The more knowledge you have, the better. So the capitation rate that we pay to our MCOs, and I'll have to double check this, but I know that it is a per member per month fee, and it's just a flat fee. And I don't know how the dental is calculated and pulled up into that, but it is not carved out when we pay them a capitation payment. It's just that one flat fee. But I'll double check on that to see if there's any way to see if there is a specific amount allocated for dental. But it is just that one flat fee per member per month. And the community rating system, yeah, I don't know that I have any information on that right now, but we'd be more than happy to, if you want to leave that on the agenda as old business, we'll have some information at the next meeting for you.
Okay.
Unless any of the Medicaid staff on the call would like to, if they know and can address this particular topic.
Well, I didn't want to put anybody on the spot with some of those things because I just wanted to at least get them on the agenda so we could talk about them, learn a bit about the system, and you know, just keep learning.
Well, and to Dr. Brabowski, going back to the capitation rate for MCO dental per person recently, so we have to report to the Legislative Research Commission, I think quarterly, a report, and it's an expenditure report for Medicaid, and it is broken out by category of service. But you know, you have to really know how to look at that report because most of the expenditures are fee for service. But on that report, there is a line that shows the MCO capitation amount and providers, and it shows a per member per month how much the Medicaid program spends. It's also it shows enrollment. We have started putting that on our website, and maybe at the next meeting we could, you know, just pull up one and kind of go over and show you how to read that report, and you could kind of get a better idea of where the money in Medicaid is going.
Okay. All right. Thank you very much.
Dr. Brabowski.
Yes.
This is Stuart on WellCare. I just thought I'd mention community rating. That really applies to commercial insurers, not Medicaid. It has to do with the premiums that we charge, and we can't charge different premiums for people in the same geographic area. That's the gist of it. So this would be like marketplace, you know, qualified health plans, but anything commercial.
Okay, so it's more of a, I was making a note there, just not necessarily Medicaid. It was just more for like the insurance companies.
Right. It's the
Okay.
premiums that are charged to the insured, and it has to keep it the same within the same geographic area.
Okay. Okay.
That's what the community is.
Yes. Yes. Okay. Well, when I was reading some of that, trying to learn on some of that, is, you know, like you said, it's just kind of for that community, that area.
Right.
But I didn't know if it included Medicaid. I knew it kind of had something to do with insurance, but then I wonder, will that have anything to do with as Medicaid goes into this next plan, you know, of the 138% to the 200%, that's kind of an insurance plan, the way I look at it, but correct me if I'm wrong, but will that rating system affect the Medicaid plan?
Well, you know, that's a good question. The community engagement and paying premiums, you know, the prior administration did have that option that was shot down in federal court, but where Medicaid members did indeed pay premium, or that was a proposal that they'd pay premiums. And I'm honestly not sure if that would apply to Medicaid or not, even though they would be paying premiums. I don't think so. I still think it's just the commercial in the marketplace, but it's a good question if you're paying premiums, because that's what it, relates to. But I honestly don't know. I don't think that it applies to Medicaid, but I can't say definitively.
I know on some of those things, they, since Medicaid is kind of its own entity, sometimes the other rules don't apply to that. And I cannot give you any example right off the top of my head, but yes, Stuart, thanks a lot for that information. I appreciate it.
Sure.
Now, on the next item, well, is there any other new business from any TAC member that I maybe forgot to put on the agenda? Couple of questions. Well, let me make one comment. We talk about the failed appointments, and especially in the Medicaid group of folks. But this happens to any and all dental patients. Back in the 80s, I was one of 10 dentists out of 4 states that was invited to do a program through the University of Kentucky, and it was called the Dental Fear Program. And it was a pretty long ordeal, about a year-long study and stuff. And we had to go to meetings and had to interview patients and stuff about dental fear. And you all know sometimes going to the dentist is sometimes not the most fun thing to do, but we have to do it. But earlier this week, I had a young person in that maybe in their 20s or something like that, a young lady said, I would rather deal with a broken bone as to have a shot in my mouth. Now, but that's what fear can do to folks. To me, that's just not even rational to put up with a broken arm or a leg, having the healing process and walking around on crutches or a boot, for a 30-second, 45-second injection, and then I've had so many people say, well, I didn't even feel that, so the fear creates these unreal expectations sometimes, but the one of the things, and I mentioned that to you just to bring this up for maybe us to look at a study, and in access to care, and at the same time trying to get our children seen and to try to develop the trust between the child and the dentist, the dental staff, the dental office, and also to identify, areas in the state, where there might be some weaknesses in access to care, maybe on a percentage basis. But what I would like to propose is for, the Medicaid staff and the MCOs to maybe let's do a focus on our children and maybe do a kids, maybe panels, the wrong word to use, like maybe moms with kids or pregnant moms, and let's start at a young age of trying to get folks in to the dental office for cleanings, exams, and maybe to look at I know the MCOs have got reports on each of their members. Well, and I'm sure, like I know my computer system will bring it up when they had their last cleaning. So if we could work on a format, and I don't have one in front of me, so bear with me on that. I do not have a format, and each of our computer programs will let us do this or that. But if we could work on some kind of a format, and then also if we see areas of needs, what can the MCOs or the fee-for-service folks do for target outreach on getting these folks back into the dental office? Because the more and again, I'm going back to my story about the dental fear program. The more experiences that these children have that are good, it leaves a better relationship with their oral health and growing up. How many of you have heard the horrible stories about, the treatment that a child received? And you all know that when we're children, we're 7, 8, 9, 10 years old. I mean, everything is magnified to the nth degree of pain associated, or just the color of the walls in the dental office. Because I remember that when I was about that age, of a drab old dental office. But anyway, I won't go into more of that. But I don't know, can anybody help give us some guidance or give us some thoughts on that idea? Well, that's good. That means it's 100% go. So but I'll try to reach out to, if the MCOs want to contact me or email me on some ideas, or how can we put this package together. But I would like to propose it as a motion that we look at this. So I would need a second, then we could vote on it.
So, Dr. Bobrowski, this is Christy Medina from DentaQuest. We actually were hoping to share some different initiatives that we were going to be launching in the Commonwealth in the upcoming months that kind of ties into that. I know it's not anything that's mandatory or that can, it's just kind of something that we're doing for the Anthem Blue Cross Blue Shield health plan. Would you want us to kind of jump into that, or if it's okay, or do you want to go ahead and take your vote first?
I guess technically we better take a vote first, because
Okay.
if it gets voted down, then we don't have anything to do, Christy. So,
Okay.
All right, I'll make the motion to work on developing a mechanism to look at our children that haven't been into the dentist for the last 6 months, and to follow up with them and their parents, moms with kids and pregnant moms, and as a second part of that, to do a target outreach to those Medicaid members of encouragement to get them back in. So I'll wait just a few more seconds for a second on that idea. If we don't get a second, it'll die for lack of a second.
This is Stephanie Cam from United Healthcare. I'll second that motion.
I think you have to be a TAC member.
Garth,
Yes,
I'll second
Stephanie.
it. This is Phil. I'll second it.
Okay. TAC members voting, all in favor, say aye.
Aye.
Okay.
Aye.
Any opposed? Okay. Thank you. So now, Ms. Christie, if you all want to, or do you have any other comments about it right yet?
No, we do, and actually, we can kind of share just a quick one pager. Lauren Locke can bring it up, but basically, it ties into some of the things that you were talking about with engaging the member community, right? Just kind of pushing those preventive visits, kind of trying to change and alter some of those behaviors and misperceptions about dentistry, I guess, right? It would be the appropriate term, where it doesn't necessarily have to be where you have to wait to go into an office when you're in pain, right? Like if you go for your regular visits, you can kind of get things on the front end, and it won't necessarily complicate a treatment plan or the services that are needed. Lauren Locke is actually gonna pull it up, and we can kind of just share that with you. But one of Dr. Bobrovsky, one of the things that at least we see from our perspective is not all members have history at the dentist. Some of these, enrollees that come into the Medicaid program, we don't have history for them. And so it's very difficult, from a health plan perspective to, remind them to go to their dentist. It's more, we do send out those type of reminders regularly, but, they don't have a specific provider with that history. So one of the initiatives that, we're trying to roll out is to implement a dental home type model. And we're actually looking to launch that in September. So in the upcoming weeks, and I apologize, but it looks like screen sharing is disabled. But what we can do is we can just go ahead and share the document.
I made her a co-host. She should be able to share her screen.
Okay. Awesome. Thank you. But just kind of putting an assignment in place, for each of the members. We've been working with the provider network, our panel of providers that would be able to kind of serve as that PCD, that primary care dentist, for both the children and the adults, and putting that information on their ID cards just to kind of serve as that reminder of, who their dentist is, who they're able to go seek care from on a regular basis. And then that way, on a regular basis, we would be able to just like you mentioned, remind them, we've noticed you haven't been, for your cleaning in, the past 6 months and things like that. So we've been working pretty diligently with the providers to assess their capacity, obviously kind of keeping that in mind, where, we don't want to necessarily overwhelm any offices that might not be taking new patients and things of that nature, but, making sure that, we're able to assign folks, at a rate that is, sustainable for our provider community. So that's one of the things that we've been launching and working towards, and we're really excited that, we're able to roll that out.
Well, that sounds great. And Christy, if you don't mind, I would, if you could send me, I need some additional contact information. I think I've got your email address, but just if you got a phone number or any other people that from DentaQuest, I need to get your some of your contact information. So if you've got some folks that want to share that with me, just you can get back with me through my email. There would be fine.
Absolutely. I'll go ahead and share that with you. And then one of the other things we just wanted to kind of talk about is that, and again, we'll kind of distribute this to the folks, is we also launched a program, kind of an outreach campaign where we've gone to we've assessed areas where we're seeing that the Medicaid member utilization rate is lower than maybe some other counties or cities and things of that nature, or areas where members might be having a hard time getting into an office, right? Offices, are short-staffed and all those different challenges that I think we've all been talking about over the last several months. And so to try and combat some of those barriers, we've launched a dental days program where we will kind of go out into the community after hours, usually on the weekend, on a Saturday. We've had 5 events the past 5 months, and we've been able to service over 180 members on those days, which we're very proud of. We'll have some dentists. We've partnered with our dental director, Dr. Watson, to kind of go out there, assess members, create a treatment plan, and then with the intent to kind of go back for any care they might need, or connect them with a local office in their community that would be able to pick up the care. So we've looked at some of those more remote areas where, again, there's just dental deserts and there's just not many options to try and kind of combat some of the challenges that we've talked about.
All right.
Christy, can add something to that point?
Yes.
This is Dr. Watson.
Oh, of course. Yeah.
Yeah. So I just wanted to add, with Dr. McKee and what she put up there earlier, one of the biggest challenges is no one's available on Saturdays. Very few people are even available on Fridays. And so through this collaboration, we are going into these different areas, remote areas in Eastern and Western Kentucky on Saturdays when people are off, getting the baseline information. And we would love to collaborate and partner with practices that are in that area that may accept Medicaid. We can do like the triaging and SDF and some of those different things to arrest the decay or determine what these individuals need, sign BAA agreements with those practices so that we can, in essence, make sure that these individuals get that continuity of care, but have an idea of what they need, what their needs are. So they can be worked into schedules in some of these remote areas that might be a 3-hour drive one way from for us from Louisville. But, I think it's a great program. It's allowing a lot of people the ability to at least talk to and understand their needs, sometimes for the first time since before COVID. And it's about partnership from here.
All right. Thank you, Dr. Watson.
Awesome.
Let me close this down here. And let me get one other piece of paper up here. I had a couple other questions that have come up that if the I guess the Medicaid staff, we would like to know like what page or paragraph in the MCO contract gives the MCOs the right to, I guess, reimburse whatever level they want. Or we have a question also about down coding of the dental codes or bundling of dental codes. And we would like to know what is in the contracts that allows that to happen. Another question is per each MCO, what are the dollar amounts per year of member incentives that you provide, and especially mainly from 2015 to 2021. And I guess, and we might have to do that as just like last year, because I know those member incentives change yearly. I said member incentives, each MCO may have a different term for that. If you don't understand what I mean, please ask, because we may be talking about the same thing and we may have just named it different. I got a question for Passport. Is I understand that the Passport through Molina is going to be offering a denture service. But when are the providers going to hear more about that and reimbursement, and what are the rules for doing that procedure? But does anybody from Passport have any answer at least as of today, or you can get back with me.
Hey, Dr. Bobrowski, this is Brittany Spencer. I'm a provider services representative from Passport. So we do have a denture value-added benefit program that's going on right now. We've been outreaching to our CE team, our community engagement team has been doing some outreach to some of the dentists all across the state. In order for the dentist to be a supplier for that, there's a supplier form that they fill out, and then they have to submit a W-9 that goes through the processing level at our project manager level there. They'll be given a supplier ID number. At that point, they are able to see Passport members that are also enrolled in the community or in our chronic care management program. And as far as reimbursement, Passport does reimburse for partial or full dentures, $700 for full and $300 for partial, and then the members are responsible for any remaining. The program does reimburse the providers directly. They don't have to submit a medical claim. They submit the information on an invoice, and I can send all of that information to you so you can distribute. We've had some pretty decent participation with it thus far. I'm not sure if they've decided that they're going to continue the program into 2023, but we have several members that we work with on a daily basis, getting them in to areas all over the state for dentures. They don't cover snap-on or implant, but they do cover like full and partial plate.
Is that 700 per denture, or is that per set?
It's 700 for a full set and then 300 for a partial set. So yeah, that's 700 for full and then 300 for partial.
Yeah, that's okay. Well, yeah, if you don't mind to send me some information, I appreciate it. Let's see. And I've got another question as to how many Medicaid members were there per MCO per year going back 2015 to 2021. So that should be a relatively easy one to, but I know that with the COVID and the expansion, that number should be, well, obviously it is increasing because the commissioner reported that there's 1.6 million members on the Medicaid rolls now, but I'd just like to see the number of per MCO. Let's see. Yeah, and I think I've already asked that one. I'd like to see a report from the MCOs, even though I know the state has added or expanded the programs, on what is the total dental expenditure from the state on dental care, excluding the member incentives. But I think the commissioner is going to work on that, because I think I've been told this before, that I believe that medical and dental just run together when they give their capitation fee, if I'm correct on that. But okay. Does the any other TAC member have any other questions? Now, the next item is we've got we just finished a MAC meeting the other day. Does the TAC members, do we feel like there's any other recommendations at this point in time. We need to make a recommendation to the MAC. Okay. The other thing, I didn't exactly put it on the agenda, but I would like to let the floor be open a few minutes. If any MCO wanted to make any comments or ask any questions individually. Let's dental questions, since you all mentioned a few things a few minutes ago. Is there anything else that you'd like to say?
No, we'll go ahead and share that just quick one-page document, but you know, kind of includes some of the different things like reimbursing for missed and broken appointments, some new little codes that we added to the fee schedule. But I mean, I think from our perspective, we covered everything.
Okay.
Thank you.
Thank you. United Healthcare.
Hey, Dr. Borowski, this is Adam Rich. I don't have anything to report at this time. Thank you.
Okay. And I apologize. I didn't specifically put that on the agenda today because I just didn't know how long a couple other things were going to take, but it looks like we'll have time. Passport, any other comments?
No, nothing else. If you don't mind, could you send me your email address though, so I can forward all that information over to you, and then you can disperse as you see fit.
Okay. I can tell you real quick. It's Whitnick, WHITNIC, 2 at MSN.com.
Perfect. I'll be sending all that over to you. Thank you so much.
Thank you. Anthem, or let's say I got that one. Sorry. Humana.
Hello, Dr. Bobrowski. This is Nicole on behalf of Humana. We don't have anything else to add for today. Thank you.
Okay, what? And then Aetna and WellCare.
Dr. Borowski, I don't have anything for WellCare, but thank you for asking us.
Okay.
And the same is true for Aetna, Dr. Bobrowski. Thank you.
Okay. And please, any of the MCOs or representatives, if you've got something that you would like for us to bring up at the TAC meeting in the future, my email and phone number is always available to you all to call and we can get things on the agenda because, like I said a while ago, I think part of the duty of the TAC is for developing, specific ideas for policy development or care or just trying to work on these children so that they're not so afraid of us. But I think a lot of offices do have a very good rapport with their younger patients, but it's like every maybe not every day, but every week I just hear these adults that come in that, boy, I just remember this day at the dental office back when I was a kid, and it's like, man, I was terrorized, but it's just one of those things that sometimes kids have trauma and they have to be seen about. Sometimes these children have neglect. Sometimes these children have abuse, and we still need to be the professionals and take care of them. But the next MAC meeting is September the 22nd. The next TAC meeting is November the 4th. And I told you there'll be a Medicaid forum at the KDA annual meeting at French Lick, Indiana, for Saturday morning from 9 to noon. And like Commissioner Lee will be there, be speaking. And I know Dr. Caudle is going to be having a presentation, and Dr. Rich is going to have a presentation on antibiotic prophylaxis for knee replacements, shoulder replacements, and stuff like that. So we're looking forward to having some additional good presentations. And I've given you the new TAC member update. Let's see, I got that. Sometimes,
Bobrowski,
yes.
if I might, this is Erin. I just wanted to let you know, in the next week or two, I'll start working on the meeting calendars for next year. And I'll hope to have that out to you way before your next meeting, so you guys can vote on the days and make sure that that they work.
Okay. Appreciate that, Aaron. And I apologize that I messed up on the on getting this agenda out. I know I sent it out, and then a couple of them came back to me. Then somebody called, said they couldn't open the attachment. And then I was trying to resend it and straighten things out or whatever I thought. And boy, my computer just had a major hiccup, and it took the Apple support people and myself 2.5 hours to fix it. And I thought, yeah, those are the smart people that can do all that computer stuff, you know, and it still took 2.5 hours to fix it. So I apologize that I didn't get the agenda out quicker. Hopefully it didn't mess anybody up, but I tried. And you know, so many times that's why I'll put on there other new business or other old business, because so many times by the time I send that out, I mean, there's something that we've got to talk about and it's not on the agenda. So sometimes that's why I leave a little wiggle room in there for something to be brought up, or else it's like 3 months before we bring it up again. So there is a plot to the madness on these agendas. But all right, any other comments from any TAC members? Hearing none, it's a beautiful Friday afternoon, and I appreciate everybody's comments and participation. And please, like anytime you got thoughts or ideas, just please send me stuff, and we'll talk about it or work on it. But you all have a great weekend.
Thank you too.
Thank you.
Thanks, Garth.
Thank you. Have a good weekend.